The time is 12 minutes, 3 minutes for discussion. There are 4 speakers in this session.
I can use this one. Yes. And you are here with me to help me if need be?
Yes, sure.
Okay. This up and down. Chairpersons and learned friends, I think fractures have been healing since the ascent of man and animals on the earth. I think the most important thing to realize is that a bone is in reality a vascular tree. If you can remove all the mineral and soft tissues from the bone by any means, the bone looks like a vascular tree. It is a vascular tree which is embedded in a surrounded by mineral which is in a dynamic equilibrium. And there is nothing better than bone to replace bone when it comes to repair and regeneration. One of the most important thing in the bone is that this is one material, one tissue in the body which has a potential of self-regeneration. Once a bone is disrupted, it bleeds because it's a vascular channel. It would bleed from everywhere, from endosteal vessels, periosteal vessels, soft tissues around, and from the vessels which are actually embedded in the bone. And this, whatever bleeding accumulates, well, has been given the name of fracture hematoma since times immemorial. Today we want to call it a substrate because some changes have to take place in this mass of clotted blood. Biological cascade of fracture healing has been mentioned in the form of first stage fracture hematoma, then formation of soft callus, formation of minerals in the callus, the mineral gets deposited in the callus, callus consolidation and callus remodeling. These are all overlapping features. They don't occur in isolation, and one after the other they occur. If we show it in the form of a graph, these are overlapping things. See, one activity overlaps the other and so on. So another method of putting them in writing is stage of inflammation, which contains clot formation, organization, angiogenesis. One of the most important things which is happening in, I think this jumps around to the minimum possible touch, I suppose. One of the most important things which happens in the organization is that angiogenesis. The blood clot gets invaded by cells, mesenchymal cells, and the blood vessels. Most important activity which is going on in this callus is angiogenesis, or neoangiogenesis, because it is the blood vessels around which the new bone will form. And the bone forms from a basic cell called the mesenchymal cell, which has the potential to divide and undergo cytodifferentiation into any of these tissues, any of the mesenchymal tissues. I don't think I need it. It is for us to provide environments to this mesenchymal cell so that it can form the tissue which we desire. If we look at the cellular response at different stages, now the pictures which I am showing at this time, they are from the experimental work on bone healing or fracture healing. In the earliest stage, there is just a non-specific, I think, but it jumps around. In the earliest stage, no, I understand, but even without touching it, goes to the next slide. I think we are touching it roughly. You have to touch it like a. Okay. Okay. I think in the earliest stage, the response, the cellular response is practically non-specific, and after some time, after some time the cytodifferentiation takes place, and some of them will form osteoclast and osteoblast. You require both the things to form bone. And last of all, a clump of cells form which are called osteoblastic cells, which are usually found in experimental studies around 2nd to 4th week. Cutting cones have been described repeatedly, romantically, that cutting cone, which is nothing else but a large blood vessel or a blood space headed by a group of multinucleated cells, which can be called osteoclastic cells, and the new bone formation is all the time around the blood vessels. So-called neo-osteogenesis takes place around the blood vessels. It is just to tell the same thing. This is how a cutting cone will look like, and this is how, first of all, neovascularization, perivascular neo-osteogenesis, and then restoration of the medullary canal, which takes place in the last phase. I think every time we should be able to visualize that all the new bone forms around a big blood vessels, and these big blood vessels ultimately keep on reducing in size by multiple concentric layers of the new bone formation. Here is the histological picture. You can see multiple neo-osteogenesis, but each one of it is surrounded by so many cells. Most of them are osteoblastic cells. The earliest new bone formation, I think it jumps, earliest new bone formation taking place around a vessel, which automatically becomes lesser in size as we. Now, for example, if you look at this one, this was the first layer of bone that formed. Then there is the second layer of bone that formed, and then the third layer of bone that formed, ultimately giving rise to a classical osteome. This is the classical osteome which has formed in about in the animals in about 1 month's time. Well, this is just a diagrammatic representation of a soft callus which gets mineralized, becomes a hard callus, and ultimately reformation of the medullary canal, which is nothing else but something like remodeling. Another picture showing the same sort of story. Any displaced fracture would cause disruption of the medullary as well as periosteal blood vessels. Fortunately, the periosteal blood supply increases by 6-fold after any fracture or after any osteotomy. There has been a tendency for rigid fixation in the past few years, but if we look at how do these different modalities of treatment, closed method, plates, intermedullary nailing, how do they affect the process of fracture healing? We get adequate contact by any of these methods. Some things which matter most is what do we do to the fracture hematoma, which is the substrate. The substrate is not disturbed in closed fractures. It is maximally displaced or disturbed when we do the plates. It is minimally disturbed when we do the intermedullary nailing. I think this is a very important thing, because the substrate or the integrity of the fracture callus, integrity of that fracture hematoma is the first important thing when we think of a natural healing of a bone. Another important thing is whenever we use an implant, there are always some chances of complications. So one can think complications are least in closed fracture, more in whenever we use an implant. And implant removal, obviously, if you have not put in the implant, we don't have to remove it. Basically, it comes to choose the best of the methods of treatment, closed, plate, nailing, according to the personality of the patient. personality of the fracture as well as the personality of the patient. If the patient is too sick for tolerating any surgery, I think it is wise to use most of the cases, wise to use a closed method of treatment. Plates cause lot of disruption of the soft tissues. In fact, if you are going to put in a plate, the size of the plate should be at least 5 times the diameter of the bone at the site of the major fracture. And naturally, if you are going to put in the plate which is 5 times the diameter of the bone at the site of the fracture, the incision will have to be at least 2 centimeters more. Despite change in the mindset of people after Charlie wrote the book Closed Treatment of Common Fracture, many of the following fractures can be treated effectively non-operatively. Most of the fractures in children up to 12 years of age, most of the fractures in adults, clavicle, proximal humerus, mid-shaft humerus, distal shaft, and ankle, metacarpal, metatarsals. Closed treatment succeeds in many recently osteochondral fractures as well. We feel an osteochondral fracture can be, if it's a fresh one and if you have the C-arm facility, can be reduced closely, and we can take the advantage of a closed treatment by putting in a few K-wires which are basically put in 2 directions, multiplanar and bicortical engagement, and it appears as if many of the osteochondral fractures can be treated by practically a closed method. Some of the examples of treatment by closed method: too much of implant does not necessarily heal the fracture. Note failure of an implant and non-union. Sometimes we get into the impression that if I use too large an implant, it will heal the fracture, but it probably does not happen so. I think plating causes a lot of disruption of the soft tissues, and so-called rigid plates, they many a time end up into thinning of the bone under the plate and implant bone interface stress concentration and fracture of the bone at the implant bone interface. I think bone for its repair and regeneration requires not the technique of a cabinet maker, but the patient care of an understanding gardener. This is what was given by Girdlestone in 1932. Let's be wary of jet-set Darwinian evolution of surgeons who believe that for every orthopedic disorder, operative treatment gives better results than non-operative treatment, and with operative treatment with implant fixation, the result is further better and beneficial. Beneficial for whom? One can keep on thinking. These are pictures. The upper one is an osteoblast and the lower one is an osteoclast. You need both of them to work in balance, and one should know, I think as young students we should know, that one osteoclast can compensate the work being done by 10 osteoblasts. 10 osteoblastic activities are equivalent to 1 osteoclastic activity. Thank you, sir. Thank you very much.
Thank you, sir. As a student of orthopedics, we are always learning from you. So we learned a lot from this lecture also. I think because we'll follow the similar subject, and we invite Professor Midha for his talk on augmentation of bone healing.
Good afternoon, Chairman and friends. I'm happy that Professor Tuli started with a natural process of bone healing, and I'm going to discuss how to augment the process. As he pointed out, bone is the tissue which heals by formation of its own kind. Rest all soft tissues, they heal by formation of scar tissue, but here the bone, it heals with the formation of bone itself. Even then, 5 to 10% of fractures may show a delayed or impairment of the healing process. Bone grafting is known to surgeons for a long time, But yes, the resources are limited and it leads to increased morbidity from the donor side. So definitely strategies have to evolve to improve treatment of these cases with impaired healing. And even surgeons and patients are started thinking of how to enhance healing of an acute fracture. And spinal fusion always been a difficulty because of the healing process problems. I will start with using physical methods. Mechanical stimulation has been known to surgeons for a long time that stimulates the healing process, and the experimental studies have shown that the healing process enhanced if the peak strain of above 0.4% for an adult femur, that will amount to 2 millimeters displacement at a load cycles above 0.5 hertz, is known to encourage healing process. Ken Wright in his experiments on canine tibia showed that if axial movement of 1 millimeter displacement is applied to external frame at the fracture site, it significantly reduces the healing time with lower rate of secondary surgery. He repeated the experiment with human beings as well, and on patients with acute tibial fracture he showed that increases the healing process and shortens the healing time. Electromagnetic fields have been used for decades by invasive methods, by directly implanting a electrode at the fracture site or by induction through a capacitive coupling or inductive coupling, and in clinical settings 64 to 87% success rate have been reported for tibial shaft non-unions. In a double-blind study, it's a prospective study on 23 patients with non-union with a mean duration of 28 months. Scott and his friends showed that non-union healed in 6 of the 10 fractures who have been managed actively, while in placebo, where there only coils were put but there is no induction done, none of them healed, which was a highly significant finding. It's a commercially available method, though a bit expensive. The latest mechanical way to add to the healing is low intensity ultrasound. It has effect on the cell biology and hastens the formation of soft callus, and efficacy has been confirmed in animal and clinical settings with a low intensity ultrasound, which is introduced during the first week after fractures and applied at least for 20 minutes per day. And it has been shown in experimental in a randomized double-blind study on 67 fractures of tibial shaft. It showed that there is significant decrease in time to clinical healing. At 90 days, almost 60% of the fractures with ultrasound applied to them showed healing, complete healing, as compared to those where it was not done, only 19% showed healing. Patients showed excellent compliance with no serious complications. Another study on the distal radius fractures, the authors concluded that it accelerates the healing process of the fracture, distal radius fractures. If ultrasound is applied to the fracture site, with reduction, the loss of reduction, even malunion rate was reduced because ultrasound hastens the healing process. That brings me to the biological methods of healing. The strategies used for this augmentation through biological methods have been classically classified, has been described by using osteoconductive biomaterials or osteoinductive biomaterials, where the growth regulatory factors have been on carriers have been put at the fracture site, or by really putting in material which causes osteogenesis. We will go one by one through them. Osteoconduction is a process where the scaffold is there, but it is the host bone which contributes to the healing process. And natural and synthetic osteoconductive materials are available in form of hydroxyapatite and tricalcium phosphates, which are more popular. The synthetic polymers and bioactive glasses are the new additions to this list. There are 2 studies which really made me very interested. One by Pujols on 40 patients with closed tibial fractures where metaphyseal bone loss was detected. A porous hydroxyapatite against bone graft was compared and showed equally efficacious. Another study from 1992, which was a randomized clinical trial on 267, that's a big number, with fresh fractures, where a osteoconductive material was compared with autogenous cancellous grafts, and healing process was found to be equally well. in both of them. So they were vis-a-vis, they were comparable to using bone grafts. There was a study on the distal radius fractures where a bone cement paste marketed as Norian SRS was injected after the reduction in distal radius fractures by manipulative reduction, and the study showed that it provided a better clinical and radiological results with decreased rate of redisplacement and malunion. This cement is injected into the fracture site and sets within 10 minutes after injection compared with the conservative methods. That brings me to the osteoconductive material. As Professor Tully showed, that fracture hematoma itself is full of growth factors which act on the cell biology, which induces migration, proliferation, and differentiation of osteogenetic cells. Substances have been isolated from this fracture hematoma. There are a number of substances. The most investigated one is the bone morphogenetic protein, which was described as early as in 1965 by Urist, and they have been now produced by recombinant gene technology and available commercially, have been proved effective in animal models. But yes, even in this is another form of putting in the growth factors by using platelet-rich plasma, which is full of platelets which contribute to these growth factors. A percutaneous injection at the fracture site did show that it causes union all delayed fractures, and in 13 of the 20 non-union fractures. That was a study from clinical settings. But yes, the bone morphogenic proteins produced commercially can be delivered either by injection at the fracture site itself or on a carrier like polyester foam or collagen at the fracture site. There are two studies available. This one is randomized studies of tibial non-unions where intramedullary nail was added with a growth factor on collagen carrier at the fracture site, and it was compared with autogenous bone grafts and did show equally comparable results with clinical and radiological outcomes were statistically similar. Another prospective randomized studies from a group of investigators on 450 patients did show that adding growth factors increases the rate of bone healing with 44% reduction in the risk of failure and significantly fewer invasive interventions. That's a novel method of putting the growth factor at the fracture site by selection of a viral vector and deleting any genome which can cause its replication, but adding a therapeutic DNA which, when implanted at the site, will enter into the target cell and transduce it to produce growth hormones which causes bone healing and increases the formation of callus. That's an investigated method. These vectors can be introduced into the fibroblast either in vivo, that's at the fracture site by injection at the fracture site, or in vitro by doing it outside in a lab and then implanting those cells with the virus itself at the fracture site to cause increased healing at the non-union site. That brings me to the last of it, osteogenic biomaterials. We have known these cancellous and corticocancel grafts, but autogenous bone marrow is a big source of osteogenic biomaterials. A study from Gwalior or from India on 20 fractures of long bones injecting autogenous bone marrow did show that 17 of these 20 healed. But there was little information available on the number and the concentration of osteogenic cells which can affect the repair. And the study reported in 2005 did show that this number and concentration of progenitor cells in the bone marrow do have important role, and if in sufficient number they can cause bone to heal in non-union cases. The trick is to identify autogenous bone marrow cells and to isolate them from the bone marrow itself, amplify them in vitro by causing their multiplication, and then put them onto a scaffold of a collagen or a polymer and implanting at the fracture site. That was the way they did it in this study and showed that such a combination of autogenic cells amplified and put on a scaffold and then re-implanted at the fracture site provides an alternative to autologous bone grafting material. And it's particularly useful when the number of endogenous mesenchymal stem cells in the bone marrow aspirated is small. Then if you can augment and then put it at the fracture site, that will cause more successes. That's another study from peptide. From the left, you can see there a gap was introduced and there was nothing implanted. When on your right side, there was a scaffold of coral hydroxyapatite which is implanted with bone marrow fibroblast, and it showed a good healing. Can any systemic administration of drugs increase the bone healing? Yes, there has been a lot of studies going on the growth hormone and parathyroid hormone. Two polypeptides of parathyroid, P134 and P1284, are being used for osteoporosis, and off-label they have been used in completed fractures and non-unions with commendable results. There is a human monoclonal antibody under investigation, denosumab, which has been shown to increase bone healing by selectively inhibiting osteoclast formation. Few more materials which are under investigation for fracture healing are statins, a PTH related peptide, some thrombin derivative peptides. There are studies available in pleiotropin which have shown encouraging results to enhance bone healing in fracture setting. Future directions definitely aim at affecting this cascade of hematoma formation and conversion into a bone by doing prostaglandin agonists. And there is an oral drug available which inhibits 5-lipoxygenase, which has been shown in experimental studies to really cause faster bone healing. And now surgeons are aiming at WNT pathway of fracture healing and bone morphogenic protein signaling pathway, and if pharmacologically affected, that's a new investigation going on. My take home message for you will be: 1. Yes, because of the considerable donor site morbidity and risk with the allografts, it's important to look for other methods to enhance biological process of fracture healing. Electromagnetic induction has been in clinical use. Low intensity ultrasound has shown promising results. Recombinant human growth factors put on carriers are in clinical use, but the high cost, especially in our country, has been the hurdle. Bone marrow fibroblast after amplification and loading onto a scaffold provide an alternative to bone grafts, especially if required in large amounts. And gene therapy has shown promise, while pharmacological enhancement of fracture healing is the new line of investigations and worth considering. Thank you very much. Greetings from Gwalior.
Thanks, Dr. Mita. It's an excellent lecture. Bird's eye view of the augmentation of the bone healing. We'll take the questions later on because the next speaker, Dr. J. Naresh Babu, from here he has to go to deliver another lecture in another hall. So Dr. Tong will introduce.
Dr. Naresh will speak on etiology of disc degeneration, another important issue of basic sciences.
पेन ड्राइव दे दो can have a look on the next session. No, it's not there.
Good afternoon. Yeah. Good afternoon. I would like at the outset I would like to thank the Professor Sharaf for being invited me to give a talk on our research on disc degeneration. So these basically intervertebral discs are the pads of fibrocartilages, and they resist the spinal compression while permitting the limited movements of the spine, and they help in spreading the loading evenly to counterbalance the shock absorption of the spine. But you keep seeing the disc being degenerated with the age and with the specific mechanical insult leading into darkness of the disc and losing of water content of the disc. The nucleus pulposus is a proteoglycan and water gel held together loosely by a irregular network of fine collagens and elastin fibers. These proteoglycans are responsible for actually imbibing the water, which keeps the integrity of the disc and maintains the disc pressure inside. But once you lose the water content of the disc, then it becomes shriveled and then becomes degenerated. Similarly, the annulus fibrosus is a lamellae of cryphon collagen, which are obliquely oriented into reverse direction successive layers. These are compared like a radial tear. Once we have degeneration, there will be fissures forming on the outer side of the layer, which leads to disc degeneration and then disc prolapse in the later stage. The dehydration is endemic to a human body. So age-related changes occurs on the corners of our smiles and the skin, and the hair turning gray and the lens become opaque. These are all due to degeneration and dehydration, which results in degeneration. But if you see, skin is profusely vascular and high cell content and actively secretes matrix that maintains its moisture. This is a highly cellular tissue which produces the matrix and imbibes the water and causes the disc hydration. But in sharp contrast, the intervertebral disc is avascular, aneural, and relies on the cell content of 1% to maintain the structural and functional capacity of the disc. So what causes disc degeneration? Is it the genetic factors, or the environmental factors, or aging, or mechanical factors? So is it the aging process or a disease? Is the natural accelerated aging is the one which we need to understand. So is the aging or is the mechanical loads which causes the degeneration and disc being degenerated. So if it is genetic influence, then we see these kind of multiple discs being degenerated at the same time. But if you keep seeing the patients with a single level of degenerations, which could be the reason, could be the mechanical insult in these patients. But we also see the mechanical insult usually happens in the lower discs, but sometimes we keep seeing the discs happening in the middle of the disc. So there's multifactorial and there are many reasons for the disc degeneration. But if you see the final common pathway of disc degeneration is the alteration in diffusion is the final common pathway. So what controls the diffusion is the one which we need to understand. The diffusion is very difficult to measure in a human body. There have been a lot of studies to study this diffusion in a human body by injecting radioactive materials. And in vivo experiments are done, and the animal experiments are also being done, and then the histological studies have done to actually know the amount of diffusion happening in the discs. But all these discs, all these experiments are experimental investigations and the invasive procedures. We cannot follow the same philosophy to study the disc diffusion in humans, because even putting a needle inside the disc causes disc degeneration. So we have to have some kind of methodology wherein we can study the disc diffusion without being invasive in nature. So this is one of the concepts which we have tried. This is a post-contrast MRI study. In post-contrast MRI study, we inject the contrast into the intravenously and then take the serial MRIs over a period of time. These are taken at the pre-contrast 10 minutes, 2 hours, 6 hours, and at 24 hours. Then we start measuring the amount of enhancement happening inside the disc, by which we can actually see how much of nutrition is coming to the disc and how much of diffusion being happened in the disc. In our study, we have 215 discs in 43 human subjects, 10 were volunteers, 33 were patients, and we have classified 96 normal discs and 54 degenerated discs, and few of the discs which are degenerated we have removed from the study. Interestingly, what we see is the band of enhancement which happens at 6 hours after giving the dye. So it's a very slow process. Once you give dye, it takes 6 hours for the dye to reach the intervertebral disc. And then the bands which are forming after 6 hours are parallel to the end plate. They are not parallel to the annulus, they are parallel to the end plate, meaning that most of the diffusion is coming from the vertebral body into the disc rather than from the periphery of the annulus into the disc. So if you plot a graph on these things, usually we will say vertebral body enhances immediately. You can say this is the vertebral body which enhances immediately. So there is some problem. Yeah, vertebral body enhances immediately at 10 minutes and then loses its enhancement over a period of time. But the end plate enhances at 2 hours and the intervertebral disc enhances at 6 hours. It's like a marching of the diffusion happening from the vertebral body to the end plate to the intervertebral disc. So if you diagrammatically, if you want to describe these things, the diffusion from the vertebral body happens and there is a delay at the end plate which controls the diffusion. Once you cross the delay after 2 hours, the nutrition actually enters into the intervertebral disc and maintains the nutrition of the disc. So what is most important is the end plate which controls the diffusion, or it is the nucleus pulposus or the annulus which is main culprit for the disc diffusion and which leads to degeneration in the later date. So we wanted to study actually which controls the diffusion. For this we use a model wherein there is end plate break. There is a break in the end plate. I want to analyze what happens if there is a break in the end plate. If there is a break in the end plate, what we notice is immediately after giving dye, entire disk enhances, but the enhancement is not sustained over a period of time and then slowly loses its enhancement, and there is no diffusion march and there is no end plate delay. Meaning that if there is an end plate, intact end plate, so there is a end plate delay and it takes 2 hours for the dye to transfer into the disk. But if there is an end plate break, the dye directly leaks into the intervertebral disk. But it is not sustained. Over a period of time, the dye starts leaking out of the intervertebral disk also. So there is direct entry and direct exit. So that causes the disk degeneration. If you have more multiple end plate breaks, that results in earlier degeneration in these patients. So once there is end plate break, there is a drop in nucleus pulposus pressure, increase in matrix proteins and matrix degeneration, inflammatory response instigates, and then autoimmune response happens and alterations in the metabolite transport results in disk nutrition and increased cell death. So this is the one which got our ISIL's prize for documenting the normal diffusion pattern over a period of 24 hours. Then comes how do you differentiate between aging disk and the degenerated disk. So methods to confidently differentiate healthy, aging and degenerated disk are not clearly known, because whatever is black on the disk we think it is degenerated. Whether it is aged disk or degenerated disk is one thing which we need to understand. So why we need that? Because it helps us to identify, the epidemiologist to identify the risk factors involved in disk degeneration. And if you are in the age of biological treatments, the treatments for a disk degeneration is different from the aged disk. So same methodology we followed for these patients, and we defined the aging as a length of time that a person or thing exists, and degeneration is no longer of its kind. So if you have analysis of the patient who has a normal structure, disk with normal intact structure and normal function and diffusion, they are healthy. If there is a normal structure but reduced function, it's the aging process. If there is altered structure and also altered function, it can be called as a disk degeneration. That's why we divided all patients and we analyzed the function with the disk diffusion with the post-contrast MRI study. And the type 1 pattern is intact structure and intact function. In type 2 factor is the intact structure with reduced function. It's a aging disk. If there is a abnormal diffusion pattern and gross diffusion bands are not visualized, it's a damaged structure and damaged function. These are called degenerated disks. So this study actually won the European Spine Award in 2008 for documenting these things. And then once you know this, what causes disk degeneration is a decreased nutrition to the disk. Can we increase this nutrition by giving some drug? If you have a tonic like that, if you have a disk tonic, we can increase the we can reduce the disk degeneration over a period of time. So that brings to the question, is there a Viagra for the disk disease? Can we use some medications to increase the disk to the disk? So we analyzed existing literature. We find out that end plates are vascular buds which have muscarinic receptors and the blood flow is under humoral control. So we can actually manipulate this end plate capillaries to dilate or constrict using pharmacological methods. For that, nimodipine is the drug which is usually used for cerebrovascular accidents. It blocks the calcium channel entry. It's more effective on dilating very small capillaries and selective action on the cerebrospinal vasculature. So there are some studies in the animals where in the rat tail they have examined the effect of nimodipine to cause the disk, increase the disk nutrition in the rats. So we utilized the same study. We used 20 discs in 40 end plates from 5 patients, and we have done the normal diffusion study and given the drug for 5 days, nimodipine, and then repeated the study. And then what we found out was the vertebral body enhances 7.6% after giving nimodipine for 5 days, but interestingly the intervertebral disc increases 11% of enhancement after giving the drug. So this is very interesting. Like, you know the reasons for disk degeneration, and we know that it can be manipulated and pharmacologically mediated. So in summary, disk degeneration is multifactorial, and alteration in diffusion is the final common pathway for disk degeneration, and end plate plays a key role in controlling the diffusion and degeneration. Thank you very much for your kind.
Thank you, Dr. Naresh. We can have a few questions if they are there, as our speakers has to go to next session. Is there any question? I think there is no question.
You
Sir.
used that medicine to improve the nutrition of the disc.
Not really. To use the medicine to dilate the capillaries of end plate, meaning that blood vascularity of the end plate increases and disc can get more nutrition.
Did you follow these patients or just a study?
It's only a study we did, but the therapeutic level of these things and how much drug we need to give, and these are all normal healthy volunteers. They are not diseased patients. These are not degenerated discs. Normal healthy volunteers. What the effect of nimodipine in just healthy volunteers?
Do we expect a better response in degenerated discs?
Maybe we are not very sure, so we need to try on those things. And yeah, thank you.
Thank you, Dr. Nays. Now we are having another lecture, and it will be delivered by Dr. Saraf. He'll speak on issues with titanium implants. Issues related with titanium implants.
Chairman sir, my teacher, colleagues and friends, an interesting and a bit different topic for a lecture. We all know very well that there are issues with the metals, particularly with nickel, cobalt and chrome. It's all well known. And the allergic reactions or the issues, it could be generalized like chronic fatigue syndrome, or it could be localized in the form of eczema, urticaria, swelling, style, osteomyelitis. This is all known and nothing new about it. These days, the loosening of the prosthesis or loosening the implants, which has been talked about, again, metal or reaction to the metal could be responsible for it, and there are numerous papers on this. But then the issue for today is, what about the titanium? Can they also cause some local reactions or generalized reactions, because the titanium is the metal these days is being used extensively. Another reason why we are using the titanium are its advantages: MRI compatibility, high resistance to corrosion. This is one of the metal which is very, very highly resistant to corrosion, absence of carcinogenic risk, and biocompatibility. There's no doubt that these are the advantages of this metal. But what we do not know and what has not been discussed is that, are there really any allergic reactions to titanium, because this is the metal being used so extensively these days, the spine and the fracture fixation. So friends, there are issues with titanium as well. In the subsequent slides, with the evidence, I'll show you. And remember not that everything that glitters is gold. So that's the aim of my presentation, and subsequently we are going to analyze the various papers. Now, Thewes 2001, he compared the reaction of the peri-implant tissue, that is steel versus titanium, and the end of his paper, the conclusion was that metal sensitization to both steel implants and the titanium implant is possible. That was in 2001, and after that so many studies were there. Now this is a very famous laboratory in the Germany, and look at the enormous number of 700 patients of sensitivity to the metal. I don't mean the titanium. I don't say all are orthopedic implants. Let me tell you, the titanium is extensively used by the dental surgeons, cardiothoracic surgeons or cardiologists for pacemaker, and the orthopedic surgeons. And they found that the nickel was the culprit, the most frequent allergen, followed by cadmium but then the titanium in the list was also there. So the result demonstrate that even the titanium can produce the hypersensitivity. And those 5 patients allergic to titanium, they presented with chronic fatigue syndrome, oral lichen planus, systemic dermatitis, and if you notice the slides, most of these reactions are in the oral cavity because these implants were at the dental implant. The implant failure from London hospital, their conclusion is, again it's a good paper, sensitivity to titanium, a cause for implant failure. Is it possible? Can it occur? So what they examined, the tissues from 5 patients who underwent revision operation of the failed total hip replacement were found to contain large quantities of particulate titanium in the peri-implant tissues, and monoclonal antibodies labeling, of course it was matching with the reactions taking place over there. So you may ask, we are not using the titanium for the replacement surgery, so where from this titanium was there? Well, then they say the screws uncemented total hip replacement which were used to fix the acetabular side, from there probably the titanium reached out because it was an alloy. This again a thought-provoking paper, hypersensitivity to titanium clinical and laboratory evidence by Muller from Germany. 56 patients who developed the symptoms after receiving titanium based implants were tested. Melissa test again. Now interestingly, it concludes that following removal of the implant, all 54 patients showed remarkable clinical improvement, and the data clearly demonstrate that titanium can induce clinically relevant hypersensitivity in a subgroup of patients chronically exposed by dental or endoprosthetic implant. Again, I would say not that all these 54 patients were of orthopedic implant patients, because dental again carries a very high percentage. Can it affect the fracture healing? Could find a report. It shows that impaired fracture healing and the eczema localized to the perioperative area developed upon titanium based osteosynthesis. And after removal of the titanium material, fracture healing was achieved and the eczema cleared. And parallel to this, in vitro reactivity to titanium disappeared, and the lab tests also were parallel to what the clinical symptoms were. Now, for the interest of those surgeons who are doing the spine surgery, because when we are fixing the spine, we are using the cages, we are using the pedicle screws, the connectors and the rods, and what we are using these days is the titanium. So from US Richardson, he thought, let's compare what is the serum level. So significantly higher serum titanium concentrations were observed in the subjects with titanium spinal instrumentations when compared with control. But it doesn't mean that it was significant. So it could be higher, but it doesn't mean that it is clinically significant. But the only interesting thing is this, the second para, that the patient with interbody devices had a statistically significant elevation of the serum titanium. So that was interesting. I don't know how, but if you are using the cages and the interbody implant made of titanium, then it was significant as compared to when using the screws and the implant. Well, how clinically significant is yet to know. Now with these reports, and there are many more, the question comes that why there is reaction? Why should there be a reaction to the titanium which is so biometrically friendly? Like all of the metals, titanium releases particles through the corrosion, even though we say there is no corrosion. These metals become ions in the body and binds to the body proteins, and for those who react, the body will try to attack this. So this starts a chain of reactions. Now the question comes then, is there any corrosion? is any leaching of the titanium metal from the implants which we have been using? So these are the questions. It's not my picture, one of the picture where I could get it that over a period of time is going to get some corrosion, so nothing is 100% foolproof, no metal. We are not going to use the other metals which we cannot use it. Of course there are metals but which cannot be used in the human body. So even the titanium in long term may have corrosion. But even if there is a free titanium ions, so why should there be a reaction? There are a couple of theories. It's a very complicated things, the examination of the surrounding that IB, so many of things are not very readily understood to me also, because we the orthopedic surgeons, we may not go into the details, but they all come from a very respected papers and we have to believe somehow. The present day osteolysis, again osteolysis, hip replacement, knee replacement, osteolysis, lot of issues, lot of debate, lot of talk is there. And this paper from it shows from my medical school, again a good paper, that osteolysis of bone following total hip replacement is a major clinical problem. We know it, we all examined it, nothing new. But then he also studied that what were the phenomena, what was that local phenomena which was taking place, the various reactions taking place, why should there be an osteolysis over there? Again, is the basic science issue, and the workers in that who are working the lab throughout, working on it, has come out with some of the formula and their hypothesis that that's the reason. And few more very interesting papers. So in this paper what he did, because titanium is just not one, there are so many grades of titanium, so many alloys of titanium, maybe 15 to 20 types of titanium. So he collected the 5 different titanium suppliers, okay, from different good companies, the internationally known companies. So except the iodide titanium, a nickel content was found in all others, and that was interesting. He concludes that the nickel allergy patients may develop the hypersensitivity reaction even to a low nickel contents. Hence this reaction may be falsely attributed to the titanium material itself. So measurements of ion, so the technical question what it comes to, that it means that in the production of the implant made of titanium there are issues, and probably there are contaminants because the process is lengthy and it has to undergo and so many things. So should we have the nickel free titanium material? Is it possible? And if it is possible, is it okay for we the orthopedic surgeon which are looking for many other qualities? And then 10 different types of titanium implant material was again studied, and a lot of contained traceable amount of so many other metals were found in that. So that's the basic issue. Is the allergic reaction to the pure titanium CP grade 1, or is it because of the contaminants in it? As of today, it's difficult to answer that, but I know in some hospitals there is a practice of patch test, that you put the metal. It's not as simple that just petroleum metal you put it on over the skin. It has to undergo some process, and then in vivo and in vitro there are certain tests also to know whether this sensitivity is because of titanium or is it because of some other reasons. So to conclude my talk, titanium material does contain small but consistent percentage of detectable impurities. Under specific circumstances, even a small amount can initiate such allergic reactions. Not to everyone, a very few small percentage of the patients, of the persons. Company should carry out the further research to produce the pure titanium implants without any impurities for its use as orthopedic implant. I'll repeat again, purest form of titanium. I'm not sure if we can really use it as an orthopedic material. Thank you very much.
Thank you, sir. Although we are getting delayed for the next session, but we can take few questions in this session if they are there. On fracture healing, augmentation of fracture healing, or titanium related issues.
If you permit me to make a
Sir, sir,
permit me to make a
sir,
comment.
sir, sir.
Sir.
Small very. I mean, we have been talking about BMP. I think one should know it that how costly it is. BMP to use as a fusion material for one disk space costs $4,000 US. How many people in our country will be able to afford that? Secondly, the BMP which is being marketed in commerce, which is being marketed, which is synthetically produced, can also cause complications, and it has come in the literature. So don't take it easy that BMP which is marketed, which is synthetically produced, will not create any complications. The complications are two varieties. One, an extensive osteolysis of the bones where you have put BMP. Another one is extensive production of new bone where you have put in BMP. One will cause stenosis and the other will cause lysis. To my mind, what jurists brought in was the BMP, which is innate BMP. The naturally existing BMP may be slightly different than
Commercially produced.
synthetically produced BMP. I think these two things we should keep it in mind. And whenever my young friends present papers, we should at least mention the name of local contributors. Platelet has been projected as a fracture healing process by a group of people from Allahabad itself. We should mention the names.
Thank you, sir. Thank you for nice comments.
One more comment,
Sir,
if you permit.
sir.
Electromagnetic stimulations were never done in isolation. They have always been done as a part of a standard orthopedic treatment of a delayed union or a non-union. Therefore, we cannot give credit to electromagnetic stimulations as if they are stimulators of fracture healing, because a standard orthopedic procedure has already been done, which would heal most of them.
Sir,
Dr. Mehta, maybe
Sir.
you'd like to comment.
That was the double
Please come
blind,
here.
so nothing is
Dr. Mehta, come here. No, so that everyone can hear this.
That's the multi-center double-blind study reported by Scott. He compared it with the,
How many years ago?
oh, that was almost 30 years ago, yeah. That's
it.
92, yeah. It's an old study.
sir, I want to ask a question in this regard. Is there any role of electromagnetic stimulation or ultrasonic therapy along with implants in fracture healing?
I think that's the word to be explored, yes. The clinical studies are only 5 years old. Whether with the implant that's going to affect it, yes. But people have been using ultrasound with the usual implants, yes. But in acute fractures, you don't use these methods yet. Holistically speaking,
But
they are
I
not
think they
necessary.
can cause implant loosening.
No, really, they're very low intensity
Low
ultrasounds. No, it is
Sir,
the usual ultrasound you do for your abdominal ultrasound. It is 1/10 the strength of the normal use, the low intensity ultrasound.
thank you, sir. I want to ask another simple question, basic question on fracture healing. Whether stainless steel implants or titanium implants are going to affect normal fracture healing, or they are different? Fracture healing is anyway different in these two different implants used in a normal
I
fracture.
don't think materials.
Is there any evidence? Or
Material doesn't affect
Doesn't
the process of fracture healing. It is mainly the
Biology
creating
is
the
the
right
same.
environment. Biology is the same. Whether you put
Their job is just to provide the stability.
Stability. Thank you, sir.
Material itself is the biomechanical.
I want to
biomechanics.
thank our esteemed teachers who has presented their lectures in this session. I invite the next chairpersons to conduct the next session. Thank you, sir.
I wish I had 30 minutes to start preparing for the lecture. Thank you very much for permitting me to be.
Weight.
Yes.
Go for ideal body weight.
Basically, now we can't see the BMI during the pregnancy because of gravity interest.
Look at the height and what will be the ideal body weight at that point of time.
You can empirically ask the patient that how much most of the young women nowadays becoming pregnant, they know. Most of them in-laws, mother-in-laws might not be knowing their weight, but women, I feel they know, and you can empirically it is very clear clear situation. Many times it happens that they don't know real their pre-pregnancy. Yeah, that's true. That's true.
With the oral hypoglycemia, when you use oral, when in GDM we have to keep blood sugar below 120
Very clear
milligrams throughout the
message
day. But when we use oral hypoglycemic drugs, it will be not an easy to maintain that blood glucose, because suppose the blood glucose is 130 at morning and it is 150 at lunch time. With oral hypoglycemia, it is very difficult to control to 120 milligrams. But if it is insulin, when there is a
Flexibility.
we can adjust the dose and maintain the blood glucose by around 120 milligrams.
Sure, you are very correct. That's why insulin is the non-controversial treatment for the gestational diabetes.
I feel let us give a very clear message what Professor Shi also gave, that oral drugs are at this moment of time contraindicated in pregnancy in India, at least because you don't have any good data available for that. One thing, metformin is the only drug for PCO, but even metformin as an anti-diabetic drug in gestational diabetes is still a controversy till we come with the recommendations and good Indian data also to support that. I feel at this moment of time it is good for having a knowledge and withdraw the statement. If you go through the American Diabetes Association and other authorities across globally, ACOG, what they say is at the first given, if the patient is already taking OHA and came to you with pregnancy, you stop oral drug at the first given opportunity and start insulin.